I'm going to start the webinar, but I can keep it going.
Okay.
There, I see Christopher. Well, hi, Board Member Ross.
God, that sounds so formal.
Say Christopher too. Sorry.
Thank you. I mean, we've met now. I feel like we can go there, right?
Yes. Absolutely. I hope it's sunny. It's definitely been making my day.
Hello.
Hi, Keisha. Board Member
Hi.
Brandon.
I am doing a healing circle again at 4 today, so I will be leaving a little early.
Thanks for letting us know. And I'll defer to you, Chair Chalmanek, when you want to get started.
I would, if we are, yeah, I am, let's go. Let's get going. Are we ready? Okay, so I will call the meeting of the subcommittee to order. It's a little bit after, there's a clock I haven't sprung forward. It's a little after 3. And we'll begin with just a quick roll call of the IB board members who are here.
Wonderful. And we'll call the roll. Good afternoon, all. Board Member Ross.
Present.
Board Member Brandon.
Here.
Board Member Carvalho.
Here.
And Board Member Chalmanek.
Here. Okay, let's begin with the land acknowledgement. I'll do that, and then we'll get into the meat of the meeting. We acknowledge that King County is located on the unceded traditional land of the Coast Salish people. We honor this land and its people past and present, and we are committed to directing funds and resources to organizations led by and in support of Native and Indigenous people. And with that, I don't believe we have a quorum here, so I don't believe we can take any action on anything right now if we were going to do minutes. So let's get into the meat of the meeting. We have a 2-hour meeting today. We're going to be going over some of the options for some added federal funding, as I understand it, that were in the plan as it was produced, and we'll get a presentation regarding that. And toward the end of the meeting, we're going to get an update on the staff from KCRHA working with staff of members of the governing committee on how the final report will be structured. And there were a number of questions and suggestions on structure. So we'll get a report. Alexis, are you going to do that? Okay, perfect. So we'll do that'll probably be in about the last 20 minutes of the meeting.
Thank you so much, Chair. And I'm actually wondering, as I'm seeing, we are looking for our guest speaker today, who is Debbie Thiel with Corporation for Supportive Housing. I'm wondering if we could just swap those items and start with the restructuring update, and then hoping that our guest speaker for today from Corporation for Supportive Housing is joining us. I just don't see her yet. So in the interest of time, is it okay if we
Yeah,
swap?
that's fine. And maybe if somebody can make sure to get her on, make sure she's got the right link. That would be great. So let's go with the discussions that have been going on with staff of KCRHA and the governing board members.
Give me one moment, and I'll just make sure that the team is able to contact our person. Just give me 1 second. All right. Well, thank you so much, all. In response to board member feedback from the past couple of weeks, board member as well as governing committee staff feedback, staff have been working together to try and think through ways that we can restructure the plan to really elevate and clarify elements of the plan, clarify policy implications, as well as make the plan much more readable and concise. And to that effect, we're coming forward today with an update on some of that work and wanting to get some initial reactions today. And again, wanting to show progress on how we are being responsive to your feedback and absolutely hearing that some of the restructuring was really needed to, again, make for a stronger plan. And so I'm going to be walking through some of the restructuring pieces. And with that, I'm going to get us rolling. If you give me one moment to share my screen. Perfect. So what I'm walking through is a restructured way, really looking at the 5-year plan and starting us off with ways to really count ways that we can really regard homelessness. And so when we look at the scale of the issue at hand, we know that there are a number of ways to count homelessness. We've examined and looked at statistical projections. We've also looked at our administrative data sets, really seeing who was showing up in HMIS, Behavioral Health Recovery Division data, Healthcare for the Homeless Network data of who may be experiencing homelessness. We also can look at annually versus a moment in time. But what is boiling down to the main piece is that regardless of these methods, all of these numbers do indicate that we just do not have enough temporary housing and sheltering options for folks. And when we look also at the current state of our system, we can think of this with regards to 3 levels. We have what's happening individually at our service provider organizations, what's happening also within our network of homelessness services, and then what is this network of services connection with other systems such as healthcare, incarceration, school systems, foster care, and so on. And so looking at the current state, even just with our service provider organizations, we see a lot of our service providers carrying out good work to serve our unhoused neighbors, but we also are seeing across the board staffing shortages and turnover. And with staffing shortages and turnover, we can lose some of that expertise to be able to carry out trauma-informed care and person-centered care. And we see needs around the region, especially for our smaller, newer agencies, regional agencies, and by and for providers, the need for capacity building support in order to scale up and support our unhoused neighbors. When we look then also at the state of our network of homelessness services, we do see some coordination challenges when it comes to client care. So being able to quickly and rapidly transfer information around a given client or somebody who may be accessing services. So seeing that we can make improvements on the data front. But then we also have a number of underserved subregions and underserved subpopulations. Christopher, I see you have a hand raised.
I just want to, do you want questions along the way or at the end?
At the end, if that's all right with you.
Oh, no, of course, of course.
Wonderful. Thank you for clarifying. And so taking us to seeing coordination challenges, but then we also have a number of underserved subregions. So really elevating that. When we look across the 7 subregions in King County, we have some subregions with very, very limited number of emergency services. And further, we have a number of underserved subpopulations, especially when we look at, for example, our data does indicate we know that trans and gender nonconforming individuals disproportionately experience homelessness, and we have no tailored resources within this region that are homelessness services to meet the needs of this subpopulation. And when we look at then this network of services relationship with other systems, such as behavioral health, school systems, foster care, healthcare, carceral systems. We see warning signs and indicators of homelessness across these systems, and yet we have missed opportunities for connection and support, and further having challenges with folks who may be currently accessing homelessness services to connect and access to those other systems of care. And so thinking across these three levels, when we imagine and look towards the future of what are we shooting towards as a system, we're looking at an ideal state where every service provider is able to adequately retain and hire and retain trained staff to carry out best practices when serving our unhoused neighbors. And our service providers are coordinated and working together with data. Every subregion has services, and all disproportionately impacted subpopulations are served. And when we look at this network of services relationship with other systems, we see no missed opportunities to intercept someone becoming homelessness and how we can have supportive transitions between and throughout. And so looking at then how we go about doing this, this is where we really get into some of the key actions within the plan. And so this is where we would be diving into the key programmatic initiatives, which you all have come to know and love and have reviewed heavily, all of the initiatives that we've been working through in the plan, but then having a separate section that really talks about the funding strategy shift that we're pursuing as an entity. And so starting us off within our key programmatic initiatives, looking first at prioritizing and grouping these tables by first year 1 activities and then years 2 through 5. And so just to give an example of how we're shaping up this section, grouping into a year 1 activity. And so this is how the table that kind of best exemplifies the initiatives or activities would be represented. Here's just, for example, the family homelessness section that we're kind of considering. Having a structured table that essentially states the key activity we're taking up, what level of change that system that speaks to. So is it that individual organizational level? Is it the coordination of services, or is it that system to system connection? Are there any funding implications for moving forward with that piece? And then what is the anticipated impact of being able to carry out that thing? And then, as you can see at the top of this table, we have a bit of a paragraph that grounds us in some of the recent information, some of the information we have in HMIS and the current landscape, but being able to link in, and you can see this hyperlink here, which if somebody clicked on this, they would be taken to a page that really includes much more detailed information around all of the initiatives, all of the data, all of the work. And so our idea here in this restructuring is really making it concise around here are the actions, here's the level of change, here's the funding implications, the potential impact, keeping it concise, but being able to link out and maintain all of the really, really important narrative pieces, but keeping this main body of the plan really structured and focused on what's happening year 1 across these various subpopulations, and then what's happening years 2 through 5. That's how we're looking at restructuring some of the initiative pieces, and then taking us to the next section, which we'll be covering today, looking at the funding strategy section focused on foundational community supports payment reform, specifically KCRHA, and you'll hear more about this today. That's the focus of our conversation, how Corporation for Supportive Housing is proposing a 3-phase approach for maximizing Medicaid tenancy support for services in King County. And then focusing then the final section in identifying the funding need, but then also again bringing forward that 10%, like what we would do if we had a 10% budget increase, what would that funding go towards across the plan? And similarly, if there was an increase in budget to 50%. And so wanted to, again, roll this out sooner rather than later, since we've been having conversations across, with staff from various caucuses to try and formulate how we can really drill down and restructure the plan so it is much clearer, more concise. This would take us away from a 133 primary document, but something much more focused into maybe the double-digit range rather than triple-digit, but still being able to maintain and all of the initiatives that we've been working in partnership on and have vetted heavily with our service provider community. So at this point, I'm going to stop sharing my screen and would love some initial reactions, questions, or responses to this potential restructuring of the plan.
So Christopher, you had a question, and then we'll do Paula and Okisha, and then I've got a couple of questions.
I've got a couple, but I'll try and let me just do one first. It was an easy one, and then we'll come back to the others. And in regards to when you showed the slide current state, and then the first one was around service providers, the issues associated with them. One of the hot button issues, and I'm taking this somewhat anecdotally, so forgive me if I'm perpetuating more of an old situation or not a rumor, but one that I've heard about in the past. Part of the service provider current state challenges are still timeliness of payments out of CHA. I'm sorry, out of RHA. And did that get captured, or is that still somewhere in the, that's kind of a landscape reality that it's been brought up again and again. I don't want to belabor the point, but I'm just, if that's also part of the current state, is there's some culpability or possible challenges that RHA is exacerbating.
Absolutely. So appreciate you raising that. That's something that I think is important context for, namely the reality, and that's something we're working on operationally. It's not something that's currently drafted in, but I think is reasonable to really portray within the broader landscape.
Okay. I know that the service providers, I mean, just be candid about, they're complaining to me, and they're complaining, I'm sure, to others about saying one of our challenges is this. And if it's not at least even obliquely mentioned in the 5-year plan, a part of it is in state of affair, current state is stabilizing our current service providers. You mentioned at a high level wanting to make sure that they have fair and equitable pay and they can be fully staffed. There's just one more bullet below that, and that's timely payments. And if that was just memorialized, it would be a very easy win and would probably carry a lot of grace on behalf of the people that live underneath the weight of being a service provider and not getting timely payments. That was my TED Talk. Thank you.
Appreciate you raising that. Thank you.
Okay, Paula? Did you have anything, Paula?
Sure.
There you are. Great.
I just want to say I really liked the breakdown of the grid to be like, what's the data and like what is the thing, who is going to be like, you know, supporting it, what is the budget or like budgetary implication. And then I think the hyperlinks, I think that like completely makes sense. I would also just say, as like a growing and still piloting organization, like with that much hyperlinks, like you just want to be really careful that like those links don't break, because then it just becomes an unreadable document. And then the other thing, I really did like the 10% and 50% and like how we can get there. Will it be that specific though? So like, which is like a 10% increase, like, are we talking about like this program can't happen, or this program will have a budget, like a budget deficit? Because then I think that presenting, you know, one of the biggest things that providers already say is that like in the nonprofit world, having to braid together all this funding, I think it will be even stressful to be like, I mean, just for example, like rapid rehousing for youth is like maybe like a $1.5 million like project for a year, and we have 300,000, so 1.2 budget like deficit. Because then I feel like that will actually lead to more angst around what the report looks like. So I don't know if it's like, if we're gonna like have funding specifically and showing the budget deficit, or it's like with the realities, we're just going to cut whole programs, or we're just going to like do something. So I don't know. I feel like I would probably want to know more about what that 10%, 50% budget looks like in reality.
Thank you for that, board member.
Anything else, Paula? Nope. Okisha? Oh, and I see Juanita has joined us as well.
Yeah, I don't have any comments or questions or concerns at the moment.
Okay, Juanita, not quite sure when you came in, but do you have any questions for this portion of how the report might be restructured?
I apologize. My Bluetooth, I was trying to fix it and I wasn't able to hear everything. So sorry.
Okay. No,
Not fine.
No problem at all. And I will say, just as a reminder, that these do get posted to the web recorded, and I do think we want to send to the other IB members. Now, the fact that this is there and that they might want to listen into it. Alexis, do you have more examples of the restructuring to come? Or was that it?
That was today's first look, since this really was developed in the past week with some good
Thank you.
insight from the various caucuses. But again, wanted to before we went further, wanted to get an earlier touch with you all to see how this was looking to you and if it was making sense in a direction you would like to see staff continue to go towards.
So from my standpoint, and I see Simha has joined us as well. From my standpoint, I think it is going in the right direction. A couple of nitpicks. I forget what the wording was, but no more funding needed or adequate. I would just say that continue to fund at current levels, plus maybe inflation. I just, we're never going to stay at, unless I'm missing something. I'd rather have it stated that way rather than we don't need any more money for this. I am looking. That is right now, that's about all that I have to say about it. I do think that it's important to have this structured in a very straightforward way. And I do want to say, I think we've got to get the numbers hammered down as to make it easier for people to understand. Sometimes we're just counting too many different people with too many different categories, if you will. Okay. Do any like I say, Simha, I didn't see if you got in, if you saw any of the presentation.
Yeah, Alexis had sent me the slides kind of as I was joining, and I've had a chance to sort of talk about it previously, and I really love it. Like, I think it, the pieces are essentially the same, at least to my mind. Like the things we're doing, like the individual tasks. Sorry, did I freeze?
Nope, you're good.
Good. But it hangs together in a much more cohesive way to me. I don't know, it's easier for me to think about it in this way and to explain it in this way.
I guess the other is, how will the 2 through 5 look? Will it be specific to the second year, or will it just be grow by X%? Or
It's a great question. So currently the 2 tables are structured quite the same, where we're talking about these are the activities we would take up in future years. So we wanted to speak to the immediate prioritization of things that we're going to take up first across the plan. And we've really just so far bucketed the other initiatives across years 2 through 5, especially the various variables that are definitely with the agency. We want to create that flexibility, but get really clear on these are the things we want to take up year 1.
okay, and the other about the adequately funded or no new funding needed. As the agency grows and takes on other subregions, even for those core things which may be already funded, it's likely that there will be a need for funding from the sub areas to perform those services in the sub area, I would think. Or maybe I'm wrong.
Appreciate that guidance. Definitely will, as we continue to adjust the table, we'll make sure that language is reflective. The current ways that we've used that language to talk about things within the tables are in reference to activities that staff will be taking up. So more so the expenditures and staff time. For example, running a new analysis or preparing something, which is why the language states no additional funding needed, as it would really just be carried out with KCRHA staff time.
Okay, and how will it address capital funding? So purchases of buildings or leases of buildings, those sorts of things.
So as we're looking at, and I know Board Member Carvalho as well was asking for that detail on the model funding options. That's the focus of our conversation for next week.
Okay.
So being able to, and so that should speak to specifically what we're thinking of in terms of capital funding. And so just pending executive approval of some of those funding options before we bring them for you all.
Okay, and I'll go around once again with the other board members, since I was doing a little hogging there. Anybody has something popped into mind, or for any of you to ask another question? And just go ahead and
Okay.
jump right in.
I didn't get it, looking at this one, I think there weren't specific numbers, and I don't know if you had talked about numbers, but as we are moving forward, I think we've talked about the scope of the problem in a lot of different ways, and the easiest thing I think for me to understand is how many people do we expect to be unsheltered on any given night, and with our various projections, and if we can get to a stage where we can talk about our plans in kind of roughly that way, I think it'll really hit home, I think.
Okay. Okisha, Paula, Chris, any other thoughts? Simha? No, we're just there. Any other thoughts?
Yeah, Simha asked, you've asked a lot of the questions that I had, but I love the fact that you were honest with that first slide, but I also think it's comical that we're still having that question. And so is there a commitment to when that can get resolved?
To be clear, we do have a number of things within the plan that do speak to ways to measure homelessness, especially as we are really looking at being in accordance with the state level work that's being done around the statewide housing needs projections. And so I think this is a matter of like, we can talk, we're looking annually. This is the annual type of number and methodology we're using. But also I think too, that's not to say looking annually doesn't mean that the in a moment at time number is incorrect, but it's just a matter of like how we look annually versus a moment in time. And so I think to board member Reddy's point, we're talking about a also like big messaging piece of how do we kind of get folks to wrap their minds around the numbers.
I understood everything you said, and yet I still don't quite understand why it's not that complex of a question. It's a bit more binary. And it's also how we keep anchoring the dollars and why this suddenly becomes so Herculean when we look at it in aggregate. So the immediate need versus, you gave a very articulate answer. I still don't understand why it is such a complex answer for a somewhat binary question of what is not our moment in time, but our pick a methodology and lock it down. It's a moment in time or an annual. And are we budgeting everything against moment in time, or are we budgeting against everything against an annual? There feels like there's a little bit of split or bipolarism in the way we're approaching this. And the mere fact that it's your first slide and there's still conversation and there's still confusion should probably, I tell you that it's still not there. It's close, and there's a great vulnerability in putting it first, but we're not there yet.
Thank you, board member. And Chair, I do see that our speaker is on the line for today.
I just noticed that. So any other quick burning question from a IB member on the subject of kind of restructuring of the plan? If not, we'll move on to the main discussion today. Okay, I'm not seeing any. So if we can move, and if you can introduce Debbie, that would be great. Thank you. Alexis.
Thank you so much, Chair. I would, with great pleasure, love to introduce Debbie with Corporation for Supportive Housing. She is here today to talk about the Foundation of Community Support's Medicaid billing payment reform work. She's done amazing work with the KCRHA team already around with Partnership for Zero and making our peers support program specifically really work at System Advocates Workforce. And so with that, I do want to turn it over to Debbie to talk about the work that we've been doing together, but also broadly about our work, specifically looking at the strategy to really change payment reform. So Debbie, am I good to turn it over to you?
Yes. Hi, everybody. It's great to be with you today. I thank you for your interest in this topic and for having me join you today. I was thrilled when Alexis said that you all would be interested in sort of workshopping this conversation. So I have a fairly comprehensive overview of where things are in terms of this intersection of homeless services and health insurance that I want to talk with you all about. And so I am counting on you to come off mute or raise your hand and engage in conversation as we go through this. So I just couldn't tell you how excited I am to talk with you today about health insurance. I am sure that might sound like a bit of a dry subject, but in the homeless services world, it's an incredibly exciting topic because we are really in the midst right now of a major systems transformation in the space of how we serve people who have disabilities and or other complex health conditions. And I think 10 years from now, we'll look back and say, wow, why did we do it any other way? Today, we're kind of in the crunchy middle. So there's still some things to be figured out, but we're on a great path. And I really attribute locally this path to the KCRHA leadership, because until this point, we have done a pretty good job with this in King County, but it's time to go all the way. So we are very excited to be partnering with the Regional Homeless Authority to fully integrate homeless services into the Medicaid program and have health insurance pay for these services. Just by way of introduction, I am Debbie Thiel. I use she, her pronouns, and I work for a national nonprofit organization called Corporation for Supportive Housing. We are under contract with KCRHA to support this effort of increasing Medicaid coverage for services locally. And we work with many states and communities in this space and others at the intersection of housing and our public safety net systems. So I'm gonna kind of start at the beginning briefly to just set a little bit of the stage for these two parallel worlds that have been attempting to serve people with disabilities and complex health needs who have extremely low incomes and are experiencing homelessness and or unnecessary institutionalization. So if we look back at kind of the beginning of when we started to really see visible homelessness and significant increases in it. One of the pivotal moments, I'm sure many of you are familiar with this, is the deinstitutionalization of the mental health treatment system that really was in full force by the 1980s. And that was a terrific thing because living in institutions is no one's dream. And we know from the pandemic that it is not a healthy way for people to live. And we need better options in terms of housing and services. But at the time, the focus was really on these very difficult living situations for people with disabilities in institutional settings. Unfortunately, when that decision was made to deinstitutionalize care in this way, there was nothing really to replace it. So we didn't have a great alternative in terms of the housing, places for people to live that they could afford, and the services that they needed to stay stably housed and thrive in their communities. So that's kind of one piece of the background of just how our country has addressed or not addressed the needs of people with extremely low incomes who have disabilities or complex health conditions. The other is that, as we all know, we're in an affordable housing crisis here in King County and in many places up and down the West Coast. And when there's not enough affordable housing in a community, the people who experience homelessness first are people who have other challenges in their lives, especially people with disabilities, people with other complex health conditions, behavioral health conditions, diabetes, chronic heart disease, any number of additional health challenges can make it more challenging for someone to stay stably housed because of the care they need, the expenses of those services, and their extremely low incomes, which today in our country make housing unaffordable in every single community across the country. So these issues are all exacerbated by racism in our housing market. And as we see people start to fall out of housing, when the market shrinks, people of color, Black and Indigenous people in particular, end up experiencing greater rates of homelessness and unnecessary institutionalization and or cycling between them. I know you all are deeply engaged in this, this aspect of the equity issue, and just wanted to level set because in this talk today, this conversation, we are talking about a subset of people that are experiencing homelessness. So what happened? You know, we don't really have affordable housing for this group. We didn't really have community-based services to help people get housed, stay housed, and thrive in their communities. And so what happened was that responsibility fell to the quote unquote homeless system. You know, I would say 20, 30 years ago, there wasn't much of a system. There were a lot of goodwill and faith-based efforts and nonprofits trying to do their best, trying to scrape together different resources to help folks who didn't have a place to live, who needed sometimes very intensive services. And over 35 years, the homeless response system, made up of many, many providers and some local and state government efforts and federal efforts, created a way to serve people who were in this situation that they told us works for them. And that's called supportive housing. And supportive housing combines housing and services for people who need both in order to thrive. That's really what it is at its core. It has deeply affordable housing with rental subsidies in it, and it has services that are called tenancy support services to help people get reconnected to housing once they've lost their housing, and then to help them ongoing to stay stably housed. So as we look at supportive housing, and over the years, you know, it was difficult for the homeless system to cobble together the money to even create supportive housing, let alone to get money to research it. But fortunately, over time, we have been able to build an evidence base for supportive housing. I'm sure you're all familiar with 1811 Eastlake, and it's nationally known for being published in the Journal of the American Medical Association. I think Dr. Reddy is here in this group, if that's right. And we've learned much from you. And I just want to say a shout out of thanks to you to helping with some of the early work in this intersection of healthcare and housing. The 1811 project was really incredible in terms of demonstrating specifically healthcare savings. And then this is just a snippet from a great report, if you haven't heard it, from Sarah Rankin, who led a team to develop this report called Penny Wise and Pound Foolish. And it really just documents the whole evidence base and research base for integrating housing and services in supportive housing. So we talk about supportive housing as, you know, two things, housing and services. And they are quite distinct. They're totally different bureaucratic silos in terms of how they're administered. The expertise of people that run them is very different. I personally speak housing as my first language. I got into this work of Medicaid when I was at the city of Seattle, leading the lending of affordable housing. And all of the capital funders on the housing side were just feeling frustrated because there was no ongoing revenue source for the services. And we were seeing nonprofits just, you know, applying for short-term grants, trying to meet long-term goals of housing stability for their tenants, county grants, city grants, state contracts, a little bit of philanthropy, luncheons, fundraisers, bake sales, you know, it really has never been a stable revenue stream for providers who want to deliver these services. On the housing side, we did get a couple of significant chunks of resources, low-income housing tax credit, project-based Section 8. I'm not going to get into those today. We certainly can if you want to discuss them. But on the services side, there just wasn't anything comparable coming out of the feds that could enable a provider to really count on the revenue for those services. So the thing about supportive housing services is the homeless system essentially provides them now, but it's never ever going to be able to provide them to the degree that they're needed. And it really shouldn't, because homeless response is about crisis management. And these are long-term services. And so the idea that the crisis response system, that sort of out of, you know, necessity and the goodness of its heart, would just be the one to step into this void really doesn't make sense. But it has been necessary all these years. And so that's essentially how it's been going. So I'm going to do a quick check-in. If you're just kind of following along a little bit, here's a good place to perk up and think about the context for where we are today. So your executive summary is: the healthcare system deinstitutionalized mental health. Good thing. It didn't set up a way to help people with disabilities and complex health needs with housing. Not a good thing. In addition, the lack of affordable housing has been driving people with disabilities and complex health conditions who have extremely low incomes into homelessness. And this is exacerbated in the housing market for people of color by racism that is inherent in our country's system of home ownership, lending, and in our rental housing markets. As well, if you become homeless, your health is going to decrease. So we know that a lot of people who are having the experience of homelessness or unnecessary institutionalization, or who are cycling in and out of those situations, are experiencing significant additional health crises. And the homeless system did its best to get the resources together to fund these tenancy support services and paired them with housing. They proved it works in this model called supportive housing. So I'm going to just pause there to see if there's any clarifying questions or any comments anyone would like to add.
So board members, do you have any comments, questions? Just go ahead. I'm seeing a couple of shaking heads.
Okay.
Okay.
Sounds good.
Yep.
So meantime, as this is all happening in the homeless world, over in healthcare, we have primarily three ways that someone might access healthcare services. One is through a clinic. So let's say it's a behavioral health clinic and you're experiencing homelessness. The obligation would be on the patient to make an appointment for next Tuesday at 10 a.m., find the transportation to get there, know who your insurance provider is, have that insurance card, know who your doctor is, present the challenges, potentially take prescription medicine, go to a pharmacy, get that medicine, put it on your shelf or in your refrigerator. We know that these things are not possible for somebody who is experiencing homelessness. So the clinic-based system can only go so far in really serving people who are in this subset of folks in need. Another way that unfortunately people get behavioral health services is through the justice system. And you've probably heard the quote that the justice system is the largest behavioral treatment system in our country, sadly. So we know a lot of folks who have behavioral health conditions are incarcerated and in jail or prison. And then finally, in the healthcare institutions, while there's been a great effort from the healthcare system to deinstitutionalize its way of providing high levels of care, there's still a lot of people, thousands of people, that are stuck in nursing homes and or other licensed residential care settings. And we've even had problems here with people literally living in beds in hallways of hospitals. And this is all because there's nowhere to send them. There is no supportive housing to send them to. And so the healthcare system kind of holds on to them and they continue to live in institutional settings. So around the time of the Affordable Care Act, there was a lot of attention on this idea called the triple aim, which was really about helping to enhance the healthcare system to provide better care, to focus on the health of specific populations, and to reduce per capita costs in healthcare. So you can start to see where this system lens starts to really look like it could be helpful in terms of this subset of people who need services and housing. And as you can imagine, it's quite expensive to pay for somebody to live in a nursing home or in a jail, for example. It's actually more affordable to house and serve them in their own home. And so the healthcare system started to take notice of what the homeless system had been doing all these years and started to ask itself, what if these tenancy supports that have been proven effective through research could be covered by health insurance? And I love the way a colleague of mine, Tiffany, who has experienced homelessness, said to me when I was explaining this to her. She said, okay, so I used to work in a doctor's office and somebody would come in and they would say, you know, I have this need, and I'd pull up their screen and it would say, okay, do you have this kind of care? Yes. Do you have this kind of care covered? No. You have chiropractic? No. You have massage? Yes. And I could see everything that their health insurance covered. And are you saying that supportive housing services would be on the list as covered? And I said, yes, exactly. That's what we're talking about. So health insurance creating a benefit that says, if you're in need of these services, you're eligible for them under your health insurance. So I'm gonna go a little bit into how Medicaid actually works. If you're interested, this can be really fun to know. And if not, you don't have to memorize it, because the main thing is just to know that Medicaid is really not a program, it is health insurance. So I'm sure all of you have health insurance, perhaps provided by your employer or publicly funded or assisted health insurance. And that's what we're talking about when we talk about Medicaid. So it just means health insurance. And each state, the way it works is each state has what's called a Medicaid state plan. And Medicaid as a health insurance program, the federal government and the states work on it together. So they decided they were going to sort of go 50-50 in paying for it and deciding how it would be administered. So the joke is, if you've seen one Medicaid state plan, you've seen one Medicaid state plan, because the Centers for Medicare and Medicaid Services at the federal level negotiate each individual set of benefits, population served, services with each state. So states can go to the federal government, to the Centers for Medicare and Medicaid Services, and ask to add a benefit. And they can say, for example, we really think that these supportive housing services are effective, and we could, you know, maybe offset some of our expenses in the institutional approach by paying for these supportive housing services. And people would be healthier because they wouldn't have to live in institutions and they wouldn't have to live outside. And so as this evolved over time, and those of us working in the homeless services field started to get involved in healthcare, the healthcare program at the national level, CMS issued guidance to states to say, this might be something you should look into. So sort of even encouraging them to go about it. In Washington, we were ahead of the curve. We had already been asking that question and trying to figure out how to make this work for a couple of years. So by the time that guidance came out, Washington pretty soon thereafter submitted our application to be able to cover these tenancy support services with Medicaid, and eventually was approved by CMS and adopted as part of our Medicaid benefits through what's called a waiver. We adopted two benefits that we call foundational community supports, or FCS. One is these tenancy supports, which we're focusing on today, and the other is supported employment, which is also an evidence-based way of supporting people with disabilities and accessing employment. So anybody who wants to nerd out on Medicaid, if you've got a question about the way insurance works, happy to pause there. Okay, not seeing or hearing any on that.
I've never heard anyone say nerd out on Medicaid. That's gonna stick as my Thursday highlight.
I will tell you, I have heard and not understood at all so many political debates at the state level and at the state versus the federal level about Medicaid. And you solved it all with your statement. If you've seen one state Medicaid plan, you've seen one state Medicaid plan. That's all I need to know now about all of that debate, because I would have thought it was much more coordinated. So that's just fascinating.
Thanks for
I
sharing
have a
that.
question.
Yeah.
Oh, go ahead.
Yes, please.
I just was wondering about the program for people with disabilities. It's a supportive in their house. Yes, Medicaid. The FCS benefits. Can you, and like when children age out of systems, are they one of the population?
Juanita, your audio is coming in and out, but can you hear me okay? I think I caught what you're saying. Not sure.
Yes, I can hear you. Sorry about that.
Oh, okay, great. So I think you asked if children are aging out, if they could become eligible for FCS. If that's right, then the answer is yes. The age requirement is 18 right now on the housing supports, on the tenancy supports, and 16 for supported employment. And the state is requesting permission to serve people starting at 16 years of age in the tenancy supports as well.
What's the plan with that? This whole new.
Any other comments or questions?
I'll scan it and then we can email it to Lisa
I'm
Drixon.
going to keep going.
To them so we can send it.
Yes.
Okay, so yeah,
And
I'll take care of it.
glad to hear that was helpful about Medicaid. I feel like with all of this,
You proved it
if
too,
there's like
that's-
one or two gems you can take away, all the better, because as people on the implementation board, the more this opportunity becomes clear to you, I think the further we're going to go in really bringing these resources to the table. I do see there's some chats. Let me just double check. Okay, yeah, Juanita clarified aging out. Okay, great. Great. And hi, Ben. Welcome. Haven't seen you in a while. Okay, great. So
hey Debbie, great to see you again too. I was very pleased to see your name pop up there.
yeah, it's fun to think about how all this work comes together over time. So, all right, we're deep into Medicaid, and I just wanted to show you, as the first state to do this after the Centers for Medicare and Medicaid Services said it was possible. 17 have followed suit. This map, I know you can't see the color coding, but it reflects across the country where states are operating in purple a Medicaid benefit or negotiating with the feds to develop one, or in the light green or kind of yellow green, or in the planning stages, which is the teal color. So total right now, 27 states at some stage in moving in this direction to cover their tenancy support services with Medicaid. So there's also a business case to this, and I just wanted to walk you through what our current scenario is for paying for supportive housing. I'm not talking about capital in this scenario, so that, you know, the bricks and mortar dollars, but rather the rental subsidies and these services that we're talking about today. I'm using rough estimates of costs that are based on a study that we did for the Department of Commerce. I think more and more studies are coming out about the cost of housing operations and services that are at living wages for the staff that are providing those professional services. So you may see different numbers in other presentations, and just wanted to clarify that this is a point in time in our analysis as the data is coming in. So the way this currently works to fund supportive housing, you have to pay the difference between what a tenant can pay in rent and what it actually costs to run the apartment building, so or to run that unit of housing. And on average, we find really across the state, but applicable to King County, that annual cost per person is about $17,000. So again, that's over 12 months, and the tenant is paying 30% of their income toward rent. All rental housing starts with the tenant rent. So important to keep in mind as you know, advocates in this space, that these dollars aren't just going out for free. Everybody pays rent, and then we subsidize beyond the rent to what it actually costs to run the housing. So imagine $17,000 per person per year just on the operating side. So that's to run the building, all the facilities in the building, the staff, the property management, the insurance, janitorial, upkeep, repairs, those kinds of things. And right now, what we're doing, well, I'll go to the second one. So the cost of tenancy supports, which we're talking about today, is roughly somewhere around $10,000 per person per year. So when you add the two of them together, you're looking at about $27,000 per person per year. I think our nursing home, last time I heard, nursing home costs were well over $50,000 a year. And there's been a number of studies to cross-reference the costs of justice system and other institutional settings as compared to supportive housing that always demonstrate gross savings on the supportive housing investment over current status quo. So the way we're currently doing this in King County is we're saying that $27,000 needs to be paid by whatever we can come up with. And most of those sources are things like our document recording fees at the state, some of which the state administers, some of which the county administers. We have the Veterans and Human Services levy. We have the Seattle Housing Levy. A number of these sources are probably familiar to you. They're pretty flexible, and they're meant to address homelessness. So they pay for both these housing rental subsidies and for the services. So if we imagine a budget scenario where we have $27 million to spend, and I'm using that illustratively, but let's say we have $27 million in these flexible sources. And those are just examples. There's a few others that get mixed in as well. If our total cost per person is that $27,000, then we can serve 1,000 people, house and serve 1,000 people and end their homelessness. Any questions about this baseline scenario or those sources?
I have a,
I-
I have a broader question. I have a slightly broader question. How do agencies, what's involved for agencies to actually tap into these dollars?
Great question. Great question. I am going to cover that. And
Okay, good.
So yeah, but
Thank you.
but hold me to it.
Okay. Spoiler alert, got it. Thanks.
And there's also and this may come up and you may have touched on it a little bit. There's a question in the chat about who is eligible for FCS benefit and does eligibility equal a entitlement?
Oh, great. Okay, thank you for that question. I missed it. So who is eligible for FCS benefits is essentially this group that we're talking about today. People who have extremely low incomes are eligible for Medicaid health insurance, and a subset of those folks who have situations that demonstrate their health and housing needs will be eligible for FCS. So some of the criteria on the health side include behavioral health challenges, including mental illness and substance use disorders, experiencing chronic homelessness, so long-term homelessness with a disabling condition. And essentially, what I love about this criteria is that it's very comprehensive for this subset of folks. So anybody who has a disability or is really sick and living outside is likely eligible. And in Washington, we went a step further. Instead of only serving people who have already fallen into this situation, but the attempt is to go upstream a bit. So there are also criteria around the institutional stays that people are having. If they meet some of these health criteria and are also living in a jail or nursing home, they also could be eligible, and we could help them move out of that situation. Does eligibility equal an entitlement? That's a great question. So Medicaid, it is an entitlement when a benefit is part of its state plan. The Centers for Medicare and Medicaid Services will sometimes waive or add to requirements of that state plan in order to let a state do something unique. So in this case, we have an approval to do something additional to our state plan. So it does not actually, it is not actually in an entitlement status. It could be if the authority were changed, and it is certain, I would say, that the services will continue long-term because of the way Medicaid works, but it is not an entitlement, to clarify that today in Washington. Okay, and I see another, and feel free to add on if I didn't fully cover your question there, George. Okay, and then somebody needs to step out.
Yes, Okisha, thanks for being with us again this week. If there aren't any other questions, let's continue to move on. Debbie, thank you.
Okay, great. And I just saw Juanita's hand go up.
Oh, I'm sorry, Juanita, go ahead.
Oh, no, it's okay. Well, if this is really interesting, and with the Healthcare Authority, there was a I was able to and things that I found interesting, being on the monthly tribal healthcare calls that they do monthly, and it's Washington State. There was like a lot of acronyms and different resources available for supportive housing and just different opportunities that most people were not aware of at all. So that racial equity piece was, I think, really critical and needed. And people that were in substance abuse programs, treatment programs, outpatient programs, and trying to access services for them. And so there was like different parts of the state involved. So I got to hear more about this, and it's very interesting, but I just found that the lack of information, I didn't know about it. And I have children with disabilities, and one recently just signed up with mental health, and I had one hospitalized when she was very young, and we were being evicted, and we didn't have no supportive housing at all. And the Seattle Children's Hospital, nobody refers to any of these resources. So, and it was very sad. You know, obviously Medicaid was our insurance.
Juanita, your audio went off.
Oh yeah, that's all I wanted to say.
Okay.
I just wanted to vocalize that there was, within the tribes on tribal lands, didn't even know about some of these programs. And there were so many that are part of it. So it's just always good to know about these resources so that people can have equal access, and the different variety of people that are in inpatient and mental health settings, hospitalized for mental health care, and then substance abuse, going into inpatient programs. And it seems like there's maybe some of these resources are helping them with rent supportive housing. So it'd just be interesting to find out, like Cowlitz, for instance, like, are they aware of this, and do they know about these entry points and how to refer their clients who are elderly, all ranges of ages? You know, it'd be interesting to learn more about it, like the Indian Health Board, like, do they know how to do this and be able to get that technology or whatever trainings that are available to learn more about it. But I just wanted to relay that. In that meeting, I was surprised. Well, and it was kind of very sad. And I hope that the healthcare authority really make it, because they're making changes and wanting to make it better and make it more equitable. But anyway, thank you for raising this up. This is very powerful. Thank you.
Thank you so much. I appreciate hearing that you know, it doesn't feel accessible enough, and that more needs to be done to get information out, both for providers like Seattle Indian Health Board and for people who can benefit from this coverage. So we are partnering with KCHRA now to help make this program even better, and that's really important feedback. So thank you.
And just another real quick question. I mean, I also learned that tribes, it was in the state of Minnesota, the tribes were not allowed to access COC funding, and often on the reservation. And so that was really new news to me. And I know that tribes have their own resources too as well, but for enrolled members that are in urban areas that don't have tribal, have access, they were also given the opportunity through the Alliance and getting support and how to access, and they opened that door for them. And I was wanting to learn more about that for here, for our communities, and that would really widen, you know, I believe that a lot of people would get help and be able, and a lot of people need supports, because when you're chronically homeless and mental health, I mean, who advocates for you? Substance abuse, you know, programs like, does DSHS help with these resources, referrals, or, you know what I mean, to be able to apply and get those needs met?
Yeah, great questions. And it was really exciting to see that COC funds now can go to tribes. So maybe that's something that somebody from KCRHA could follow up on, and how that's applying here locally. Thanks for mentioning that. Okay, so I'm just gonna walk you through the math problem with the Medicaid scenario. So same situation here, cost of rental subsidies. cost of tenancy supports. And what we did is we moved all those flexible dollars up to just cover their rental subsidies and plugged in Medicaid. And currently that dollar amount is somewhere around $7,200 per person per year, which would leave some dollars remaining to be covered by flexible dollars, and puts the total costs on the local system at $19,800 instead of $27,000. So if we have that same budget scenario of 27 million available, and our cost per person now goes down to 19,800, we can actually serve 1,364 people. So that's ending homelessness for 36% more people than our current status quo. And you know, to me, if this isn't the argument to make it happen, I don't know what is, because all those flexible dollars could be stretched so much further to pay for rental subsidies if the healthcare system covered, if Medicaid covered the healthcare services. There is work being done right now. There's a rate study being done where the healthcare authority is determining, is the $7,200 the right amount? Should it be higher? Providers are certainly saying yes, it should. So that also could be a contributor to how in King County more people are housed and served. Any questions about this dollars and cents part of it? Okay. Pretty straightforward. So where are we in implementation? This is a snapshot of enrollments from maybe a month or so ago, and these are the different regions across the state, the way the state looks at them in terms of FCS, foundational community supports, tenancy support services, enrollments. And you can see there that Spokane has more enrollments than King right now, which population-wise just doesn't add up. So what we in KCRHA have started to do is ask the question, why is this? Why are enrollments low, relatively quite low in King County? And wouldn't it be incredibly beneficial to everyone involved if we could bring more of this Medicaid coverage to our services and stretch our local dollars further? So the work that we have embarked on together really, again, comes from leadership from KCRHA. We've been knocking at the door of lots of folks for the last few years to try to crack this nut in King County. And really wasn't until the Regional Homeless Authority was established that we started to see movement locally. And Mark in particular just immediately understood this and wanted to make it happen. So we're really excited to be partnering with you all in this work. And again, I think 10 years from now, we'll wonder why we didn't do it sooner. And so what we're actually doing is a number of things. One, CSH, my organization, is providing technical assistance to the authority to actually become an FCS eligible entity. And the system advocates that are working with people outside to help them get into more stable living situations could actually be covered. Their services that they're delivering could be covered by billing Medicaid. And we're getting really close on that. So we're very encouraged. The KCRHA team led by Sam Oppenheimer has been incredible in just deep diving into this. There's a lot of back office support from finance, and it takes a lot to do this, and that's one of the things that we want to really make sure we're addressing during this major system change. I think KCRHA has a lot under their belt now that can help other providers in pursuing this as well. So we do anticipate that KCRHA will be drawing these resources in directly, as well as supporting the capacity of the rest of the nonprofit sector that is often really excellent at doing this and already doing it all the time, but just doesn't have the Medicaid coverage for it. And so what we did is CSH with KCRHA support went and interviewed providers who are currently billing FCS and providers who are not yet billing FCS to ask them, what's working about this? What isn't working about this? Why are you doing it? Why aren't you, why aren't you doing it more? And we came up with a list of several ways that we think the program could be more user-friendly to providers. Because, and I think this gets a bit to what you were saying, Juanita, about, tribes doing this work, or Seattle Indian Health Board, for example, is we found that there are no BIPOC-led, Black, Indigenous, or other people of color-led organizations, or organizations specifically for those groups, that are doing FCS right now, that are billing Medicaid for these services. So there's a barrier there that we need to get into. I think in part it's because of what Juanita spoke to in terms of the word isn't out, and there just hasn't been enough engagement. There's also some apprehension about fronting the money before the Medicaid reimbursement comes in, the financial requirements of Medicaid, and like the auditing requirements are different. We're talking about insurance. So there's got to be a good bit of documentation and a lot of financial management that's new for providers that have been delivering these services under more flexible grants. And we don't necessarily want to put all that on the providers. It's just really important that especially the financial risk, I think, is borne by the community overall, so that we can get this revenue flowing. Eventually, it's going to be a phenomenal ongoing resource, but there's some startup costs. Providers need to update their IT systems, maybe hire in financial expertise, consultants or staff. They need to build their caseloads and start billing Medicaid because Medicaid's all reimbursement. So before they can get that revenue flowing. So we're talking with We Are In as well about these large scale capacity building investments to help the provider network really get on their feet with this major systems change and be able to get their arms around it. And we're telling the whole country about this, that if you want to do this right, you're asking the homeless services system to do things completely differently. You've got to support them through that. So that's a big aspect of this. And another is the systems change work. So in those interviews, we learned about aspects of the way the program is run that don't feel accessible to providers, or that feel more financially risky to them. And so we're going to be facilitating conversations among the providers who do this work and a mayor group who administers this on behalf of the state itself, and the housing department and the healthcare department. And we've met initially with the healthcare authority, and they have said, thank you, let's figure this out together. We want to be at the table with you. So I think we're going to be able to make some really strong progress there. And the regional authority and CSH are very dedicated to tracking the health and housing outcomes disaggregated by race, so that as we are starting to integrate these systems and expand on healthcare's role in addressing homelessness, we're not carrying over racial disparities that might already exist in those systems. We're really making sure that what we're creating new is founded on racial equity. We're also talking about engaging other states. Washington was one of the very first. But as I mentioned, several are engaged now, and they're all saying, how do we do this? What should the services be? How much do we pay? How do we build the capacity of the provider network? So getting some lessons learned going around the country. And Christopher, I'm just going to pause there and see if I have covered your question from earlier about provider capacity.
Yes, thank you. That answers quite a bit. I am curious about one of the things, if you said this, forgive me if I missed it. If you had or you'll address it maybe later, timing and estimated time to be able to do what you're talking about and to get the providers, because anecdotally, an old service provider agency I was affiliated with was working on becoming Medicaid approved, and it took an extraordinary amount of time. So I don't know if you have a magic wand in helping expedite the process.
Yeah, good question. I think our work with KCRHA began probably in September, somewhere around there. So I would say at the agency level, you're probably looking at a good 9 months to a year to really get up and running with this. And then in terms of building the capacity of the entire provider network, we're seeing this as a 2-year initiative. We think there's some structural challenges with the way the program's being administered that are going to need, rolling up of sleeves and sitting down and talking through them. There's lots of examples from other Medicaid programs we can pull from to set this up. One disclaimer for the state is that because this is completely brand new to literally everybody involved, CMS, the Centers for Medicare and Medicaid Services, had told the state that they were going to give them what they called a year 0. And that would be before implementation. They would have, before year 1 of implementation, they would have a year to just get started, to build capacity, to figure this all out, to set up the forms and the databases. And by the time it got approved, that had expired. And so CMS said, go. And the state really had to literally figure this out as they implemented it. So we, again, see KCRHA's leadership as an opportunity to take a step back and say, wow, that, we've been building this plans, we're flying it for 5 years. It's going quite well, but there are definitely things that if we had the time and resources to address, we could do to significantly enhance it.
Thank you.
I see Juanita had a question in the chat. Juanita, do you want to ask that and maybe elaborate? Dealt with resident programs, working with young people. Juanita, if you might be on mute still. You're not coming in very well. It's pretty spotty.
Yeah, I can.
Yeah, Debbie, from reading it, can you? Yeah, okay, thank you.
Yeah, Juanita, I see you're mentioning your children who are adults in need of this. And I'm not sure about it being intertwined with Title V or IHS. I'm not familiar with those off the top of my head, so I need to follow up with you to understand better those programs and the intersection. And resident programs that work with young people who are not independent, can they access these funds? So the way it would work is they would, their service provider would be able to provide these tenancy supports or employment supports. And so not a direct access to funds, but an access to services. And then I see George estimate the number of individuals that could potentially be covered. Oh, I wish I could. I think that I think it's a large number. I'll say that. There's been an estimate from the state that statewide we're looking at 86,000 people potentially eligible, which is much larger than we would have guessed. And we don't have that broken down by geography. I do think it is important that that is something that we're looking at locally, because again, those enrollment numbers are clearly not proportionate to our population. So getting clearer about the need will be helpful. And that's another benefit of KCRHA becoming an FCS provider, is because the coordinated entry system, potentially over time, we could integrate the eligibility for these two, for the resources that come through coordinated entry and FCS. Okay, and Dr. Reddy, curious about how much of an impact our current documentation client record systems have on the ability to become Medicaid qualified. Yeah, I would say it definitely has an impact, you know, and interestingly, it's both in terms of the physical documentation. So if you think about, and you certainly would know this, but for others, as a doctor, if somebody comes in with a broken arm and you have to fix their arm, you have to write down exactly what you did to fix the arm, and so that the insurance company will cover those costs. And so it's the same way with these tenancy supports. You have to write down exactly what you did, and it has to be the things that are coverable. So there is some training need that we've identified in how to do that really well, so that claims aren't denied and people stay enrolled. But more than that, I think it took some time to uncover this. I think there's just a bit of a culture change aspect to this that wasn't initially addressed, where if you're a nonprofit case manager doing everything you possibly can to help somebody, you know, like whatever it takes, and now you're asked for a certain amount of your day to sit down and type up notes, you know, that's not so motivating, and you feel this need, this great need. There's never enough service providers, and you have all these people in need coming to you, and so it can feel like this administrative burden to have to do that documentation. So part of what we and some of the nonprofits are doing is to, you know, really help those direct service providers understand that equation that I just shared about just how many more people we could serve if we did this through health insurance. And that definitely is motivating, but I think there's other types of just training and technical assistance that are needed to help people process this change.
Debbie, can I ask a follow-up question to that?
Yeah.
Also, super glad you're here. This is fantastic. I'm really excited about it. Yeah, documentation is the worst thing in the world. I struggle with it a lot. And transitioning to fee for service requires that, because that's what we're talking about. On the healthcare side, we have like these large EMRs that have essentially taken over, like whether it's Epic or Cerner or whatever it may be. And there are EMRs that are better and worse for documentation, or make it easier and harder to document efficiently. We don't have a standardized approach. Like we have HMIS, sort of, but it's not at least as far as I understand, it's not a place where you document your work really. Like, is there a place for the creation of essentially like an electronic client record through KCRHA for this community? Something that makes it easy and straightforward to like, did 30 minutes of transportation and, you know, et cetera, and click the box and moving on.
I think so. And our team at CSH is thinking there's a data solution to a lot of this, because some providers only use HMIS, some use their own software, some have their own electronic health records. Then we have provider one at the state, and we have AmeriGroup's Ability software system. So I don't know the exact answer to your question, but I will say that that question is on the table from our recent phase of work that we intend to answer in the next phase. Yeah. Thank you. Maybe we'll check in with you about that as we dive into it. And just to clarify that the housing, the tenancy supports is on a daily rate. So you can have a certain number of encounters over a 6-month period, and each encounter is a day. So it's not a fee for service exactly. So it is more accessible to providers in that structure. The supported employment is fee for service, 15-minute increments. Okay, and then
there's another question in the chat about, is enrollment the person had heard enrollment is capped. Is that no longer an issue?
Yeah, that's a great question because we were talking earlier about the fact that this isn't part of the Medicaid state plan. It's done through a waiver, which is a very customary way that states add benefits. There is a cap to how much money the feds are going to put into this, but we haven't reached it. And it's quite the actuarial equation to figure out exactly when we will. So for now, the state is just saying, keep going, keep going. And another aspect of this this whole program that's really exciting here in Washington is the act that was passed last year by the state called Apple Health and Homes. And what Apple Health and Homes, so Apple Health is the name of our Medicaid program. Think Washington apples, apple a day keeps the doctor away, I guess. So Apple Health and Homes integrates this healthcare services with allocations of capital and operating dollars at the state level. And it also codified these services. So essentially the state is now on the hook for paying for these services ongoing, kind of regardless of our status with Medicaid. Okay, Ruby, I know one that's in development. Oh, you know of a data solution? And that's great to know. I'm with CSH, Corporation for Supportive Housing. Sure thing. So that's it for me, and I really appreciate the dialogue. It's nice to see some faces and hear some voices in this setting, and I know this can be kind of nerdy, so but again, it's the solution. It's really going to take us to the next level. So your enthusiasm and interest and understanding of it is really important, and I want to offer myself and my team as a resource. Anytime, you know, tomorrow you wake up and you say, well, wait a minute, what was that all about? Don't hesitate, you know, I'd love to answer any questions and keep the conversation going.
Well, just because it's nerdy doesn't mean it's not exciting. So
right?
That's a good thing, right?
Okay.
May I
Any
ask
other quick, yeah, go right ahead, please.
Sorry, John, I think I have a bit
That's
of
all
a
right,
delay.
man.
Didn't mean to cut
Yeah.
you off.
No,
Debbie, thank you so much for this presentation. You know, as I think you know, we are in the midst of developing a 5-year plan for the authority, building on the good work that you did with the RAP coming up on 4 years ago now, I think, right? 3 years ago, 4 years ago. You know, and as we think about this plan, it's really important for us that this plan be one that is, you know, fully achievable with goals that are ambitious yet attainable, with funding sources that are, you know, fairly secure. And so what you're describing here definitely represents a significant increase in potential funding that could increase the number of people that are served through PSH and related models. My question for you, knowing what you do about our system and about this particular plan, is how would you think about integrating this into a 5-year plan for the RHA? Would this be like something that is so secure that we know we can do, this is total base case, and we should just basically assume that we're spending, instead of $27,000 a person for PSH, we're spending 17? Or would you think of this as being like this shouldn't be in your base case, but should be like on the list of things that you really should investigate to try and overachieve against your plan? Or is this like, don't even bother putting it in a plan, just go figure it out, you know, after you finish the plan, go spend some time working on this, or some other option beyond that?
Yeah, thanks, Fun. It is really important time to be asking that question in the 5-year plan. So I would say B would be my answer. I don't think we're ready in King County to make a cost and benefit analysis of this. And what's really exciting is that we have already done the work to find out what the challenges are in scaling this approach. But it's going to take some time, and in some ways you can think of it as a new opportunity that we are diving into fully. So I would definitely say it's an important part of the plan to name that KCRHA is doing this, and that it is a long-term strategy that will start to have benefits within the 5-year period.
Thank you.
Sure, and also just to clarify, you know, those the 27,000 that I mentioned, as I noted on that slide, it comes from a lot of county and city and state sources. So again, just, you know, check in with the authority staff about where exactly the dollars line up in terms of what's in the plan and where these dollars are coming from. There's one more in the chat. Jody asked if providers who are billing FCS have experienced issues with billable activities driving services more than the evidence base. That's such a great question. And I wish you could ask every state that at the policy development stage, because I think because this is so new, we're seeing states who, you know, are coming from a healthcare lens and not totally clear on the evidence-based services that are in supportive housing. Luckily in Washington, there's so much knowledge about supportive housing and evidence-based services that the service package that is approved by Medicaid is the one that we're already delivering and is evidence-based. So it feels really good how we're doing it here.
Okay. Other questions? Okay, I'm seeing none. Debbie, thank you so much for taking the time to be with us today. It helps explain I think there's a variety of knowledge base about all of these subjects in our implementation board, and some know what's going on and some, like me, are pretty doggone clueless about it. So we really wanted to know how this could integrate into the 5-year plan, and good to know that the agency and you are working closely together on it. So thank you.
Great, thank you so much. It was my pleasure.
Thanks. Alexis, this covers our topics. I know Ben came on a little late, and Ben, we've already done a little bit of the overview of how the plan may be restructured, and you'd be able to catch up on that maybe tomorrow once the meeting is back online. I know that was an interest of yours. Do we have anything else that you need to bring up, Alexis?
Nothing at this time, and would be happy to give folks back the gift of time unless there's any other topics. I know we had offered an opportunity for folks to weigh in on the full matrix on revisions. If there's anything board members perhaps would like to raise while we do have this time together for discussion and deliberation, happy to support that. But those were the scheduled topics for today's conversation, and want to affirm that the slides on the restructuring have been posted on the page. You can send those as a follow-up as well for folks who would like to see that written material.
Perfect. Anything else that members of the IB board have for today? Would like to raise question with staff? If not, any objection to adjournment? Seeing none, we're going to get 20 minutes back in our day. That's and we can enjoy the sunshine and the warmest day of alleged spring.
Thank you all.
Thanks very much, everyone.
Apologies again for being late.
We are adjourned. Thank you.
Take care.